thank you again for the opportunity to present here in Cali. This lecture will be on the cicatricial alopecias, present and future directions. This is a picture of the city where my university is, Minneapolis. So we all know that the lymphocytic cicatricial alopecias include lichen planopilaris, central centrifugal cicatricial alopecia, frontal fibrosing alopecia, and discoid lupus erythematosus. Chronic cutaneous LE also fits in this category. In today's presentation, we'll focus more on lichen planopilaris as a prototype for the cicatricial alopecias, and also concentrate on frontal fibrosing alopecia, a disease that appears to have been an epidemic around the world, particularly in North and South America and in Europe, less so in Asia. In terms of initially postmenopausal women presenting with regression of the hairline, perifollicular inflammation at the active margin, but now we are all seeing this disease in men and also in premenopausal women. I'm not going to spend a lot of time on the neutrophilic cicatricial alopecias, dissecting cellulitis, also known as dissecting folliculitis or folliculitis decalvans. In all cases with the cicatricial alopecias, the inflammation is around the infundibular region where the stem cells reside. And the potential for complete injury is there, but if the stem cells are not fully destroyed, there's still always the opportunity and the potential for regrowth. The histologic findings, interestingly, do not distinguish the clinical variants. So in a prospective blinded histopathologic study done a few years ago, 2 biopsies were obtained per patient from affected and unaffected, and Drs. Headington, Stan, Price, Memorani, and Willie looked at these and found that it was possible to distinguish the lymphocytic and the neutrophilic groups, but within the distinct subtypes, they really could not separate out under the microscope lichen planopilaris versus pseudopelade versus central centrifugal cicatricial alopecia, suggesting that there is a common pathway phenomenon, a generic cirrhosis of the scalp that perhaps results from several diverse causes. So the treatment of the cicatricial alopecias is always first to treat the inflammation. You want to get the disease under control. And as part of that, you have to maintain a healthy scalp. Once that period is over with and the disease is quiet, whether it happened on its own, for example, the literature would say that lichen planopilaris should resolve within 18 months. In our practice, we have patients who've had the disease for decades. But once that disease is under control with either medical therapy or the disease begins to disappear on its own, one can begin to focus on hair regrowth using a number of tools. And throughout all of this process for the patient, they have to maintain a healthy scalp. Our treatments are well known to everyone in this room. Initially, we start with high-potent corticosteroids, intralesional steroids. It was popular to use the calcineurin inhibitors along the frontal hairline in patients with frontal fibrosing alopecia. And when that fails, we add hydroxychloroquine at 400 milligrams daily or twice daily even. We add low-dose antibiotics for their anti-inflammatory effect, and even retinoids. And by this time, when a resident is seeing a patient or a student, they come out of the room saying, this patient is on a very complicated treatment regimen. They are applying this and taking this and this. The treatments we give our patients with these conditions is complex. Then, if they fail this, we move to cyclosporin, to Cellcept. We use prednisone, we might use pioglitazone, a PPAR gamma agonist, and more recently we've been adding handheld narrowband UVB devices for home use to treat the inflammation. And we can't forget when we're treating these conditions that there is a disturbance in the microbiome of the skin. In this patient, it's very clear that there is some type of superficial skin infection. But in many patients who get referred, who are on tier 1, tier 2, tier 3 therapies, and when we are asked to figure out what's going on and why they aren't responding to treatment, a biopsy of the skin for culture may be of great benefit in identifying the organism, usually Staph aureus, that is sitting lower in the follicle and not expressing itself as an acute inflammatory infection as seen on this slide. When it comes to focusing on hair growth, once you've used the tools to treat these patients, and in our practice, many of these patients have to come back every 4 to 8 weeks because of the pain that they're experiencing with their cicatricial alopecia, their lichen planopilaris, or because the inflammation is returning and the disease is progressing. But when you get them past that state, you can start introducing topical minoxidil or a 5-alpha reductase inhibitor, or both. And interestingly, low-level laser light, according to those who work in photobiology, penetrates slightly deeper into the skin, and there may be potential here to use those devices to try to target the inflammation in the bulge region. So that brings us back to what we discussed this morning, which was the symptomatic scalp. This group of patients, those with lichen planopilaris and some with frontal fibrosing alopecia, frequently describe pain, burning, paresthesias, and pruritus. Some may say their scalp feels like it is on fire. So this brings us back to those nerves. So this is a normal human scalp biopsy, and one sees the beautiful elongated anagen follicles, the sebaceous unit glands, and they call it pilosebaceous unit, but you do not see nerves well. This is a picture you saw earlier today of the bulge region, where one sees the erector pili muscle and the nerves on the top of the follicle very clearly, and it is this region that is attacked by that immune attack in the bulge region in these lymphocytic cicatricial alopecias. So that takes us back to a few years ago when PPAR gamma, or peroxisome proliferator activated receptor gamma, was found to be decreased in lichen planopilaris. And that was a turning point when people were using pioglitazone to try to treat this disease. Some successfully, others not so successfully. But we looked at this and said neuropeptide-induced inflammation may also be a major contributor to disease pathogenesis, as calcitonin gene-related peptide, one of those neuropeptides we talked about earlier today, is associated with lipid metabolism and is elevated in many chronic inflammatory conditions, while PPAR gamma expression is usually decreased. And then substance P, another neuropeptide associated with pain, can induce production and release of cytokines such as interleukin-1, 6, and TNF-alpha, in addition to PPAR gamma through the neurokinin-1 receptor. So we progressed to look at nerve and neuropeptide expression in scalp biopsy specimens from normal subjects and affected scalp skin using similar techniques that were shared earlier today. So pictorially, you will see on your left normal scalp, and on your right a biopsy from a patient with frontal fibrosing alopecia, and you can see visually that there is a decrease in the expression of the staining for the nerves, in this case in red. One sees now just the nerve stain alone, and you can see that decrease on the right is significant compared to the left using this type of pictorial analysis. And the same thing can be seen with calcitonin gene-related peptide immunoreactivity, in that there is less in the affected scalp versus the control. And then the same is seen in the epidermal nerves, in the sense that on the right, one sees very few nerves, stained now in green, on the right compared to the left, where the numbers of nerves crossing that red basement membrane are significant in number. Here one sees the decrease of the CGRP expression in the epidermis of a patient with LPP on your right, normal expression shown on your left. And in conclusion from that study, it was shown that there is a lower epidermal nerve fiber density, which translates into neuropathy, a trend towards lower CGRP expression, and similar substance P expression with both LPP and frontal fibrosing alopecia. So these findings suggest the pain that these patients experience could be related to the loss of epidermal nerves, a characteristic of small fiber neuropathy. So that brought us to Dr. Dosh Isabella joining us from the University of Sao Paulo for almost a year to study neurogenic inflammation in these two conditions. And her role was to take a look at these findings we saw and to see if one could actually see this decrease in tissue samples by using an ELISA assay. So the current perspectives are that something from the environment might be triggering these diseases along with a genetic predisposition, leading to fibrosis, inflammation, increased pro-inflammatory cytokines. There's lipid oxidation, sebaceous glands get destroyed, stem cells are impaired, PPAR gamma is decreased, and the question is, what about those neuropeptides? What do we know? What will we learn? So the neuropeptides were quantified in specimens, scalp biopsy specimens taken from the scalp. And the signs and symptoms of inflammation and degree of inflammation as seen with histopathology were studied in an attempt to figure out or better understand the role of neurogenic inflammation in these diseases to try to better understand those complaints of pain and severe itch. Biopsies were obtained from patients and controls. 4mm samples were taken along with blood samples, and these are pictures of a couple of the patients who participated, and one can see in this patient with frontal fibrosing alopecia, the biopsy was taken from the affected frontal scalp and the non-affected posterior scalp. In this patient with lichen planopilaris, the biopsies were taken from the affected scalp as shown and the posterior non-affected scalp. Histologic examination was completed and was graded moderate to intense, mild, or absent. Samples from both areas were analyzed, and the analyses were done by a dermatopathologist blinded to this study. It was found that 60% of the patients with frontal fibrosing alopecia and 80% of LPP patients had inflammation in normal appearing areas. This has been translated clinically for us to begin looking at treating these patients, not only with systemic agents, but also with overall vigorous treatment of the scalp and maintaining excellent scalp health. So the current perspective for LPP FFA pathogenesis includes all the things shown here, the potential genetic predisposition, environmental xenobiotics, dioxins, whatever you would like to put in that circle, fibrosis, inflammation, increased cytokines, lipid oxidation, sebaceous glands and stem cell impairment, loss of nerve fibers associated with decreased CGRP was found in the study, potentially a protector of the bulge region, and increased substance P. So I'd like to acknowledge for this part of the talk Dr. Isabella Dosh, and below Dr. Valenti and Dr. Ricardo Ramidi at the University of Sao Paulo. So then out of this, you have all this data, what are you going to do with it? So one of the things that we did is to think about topical gabapentin and to target